So welcome back for the afternoon session. We've got some great speakers lined up for you. So without further ado, I would like to introduce the first speaker of this afternoon session, and that's Robby De Pauw. Robby is a senior researcher at Sciensano, and he's also affiliated as a visiting professor at Ghent University. He has specialized in the disease burden of chronic diseases and has a general interest in quantitative methods. So over to you, Robby.
Thank you. All right. Thanks a lot for this nice introduction. To keep track of time. So I have the pleasure to entertain you during this afternoon session. Hopefully the food isn't tiring you too much. But yeah, we'll see. So my name is indeed Robby De Pauw. And today the idea is that I give you a brief introduction and a demonstration of how we can leverage the NEAT database. So first of all, I would like to explain a bit the background before we go into the demo of things that we consider when we were constructing and creating this database. And there are actually three core principles when we try to develop this database. The first one is, of course, that the framework which we developed during this project should, of course, be well reflected in the NEAT database. I will not give a recap of the framework. The colleagues have already gone very deep into the structure of that framework, but somehow, of course, this framework needs to be represented in the database. A second point is that the NEAT database should, of course, also have a user-friendly experience, and we have been through some iterations to improve user-friendliness, and this is also still work ongoing where we try to improve based on participations of people into the interaction with the database. And then, of course, the idea is that this NEAT database also should operate under the FAIR principles, which I will explain a bit later during this presentation. So how did it start? Well, first I want to give you two examples. So there are many examples of databases that you can find online. We at Sciensano specifically had already some experience with these kinds of databases, which are interactive. They are developed with a package or a language which is called R-Shiny. And the idea is here that there is an input that the user can include, which you can see at the left side, and then an output is generated. And that's the basic idea that we had, that somehow users should be able to interact with the data, the indicators, the criteria that we have, to get some insights in the unmet health-related needs. Another example, this is not from us, but is another way of representing the data where there is a lot of interaction. The interaction here is much higher. There is much higher real interaction possible through the user here, where you have more pop-ups, there is more linkage between the tabs, while the first example was a bit more static. And these were a bit the two examples that we took, and we tried to merge them to create a NEAT database. Of course, the NEAT database looks a bit different than this, luckily, because the concept is, of course, very different. But this was like the first setup. Like, we want to have something interactive, which the general public, in theory, but in practice, we see, of course, that it's people with a specific interest in unmet health-related needs, and professionals that are using or interacting with the data can use this database. Now, if you look to databases website in general, if you look to the usability, the user-friendliness of a database, there is an ISO guideline for this, where they set up some criteria how you can make a database interactive and how you can ensure that a user has an optimal experience. This optimal experience is in effectiveness, efficiency, and satisfaction. And actually, there are like four major groups. One is like, how is the content organized? How readable is the content? How can we navigate through the database? Is this easy? Is it linked to each other? Do we have to recreate several steps over and over again to get the same product or result? How is the user interface designed, and how is the performance and the effectiveness performance? Is it fast? Does it take a long time to, for example, find back what you are looking for, or does it take a long time for the website to load? These are a bit the four criteria which we try to improve along the way. And the demo that I will later give is at stage where we now are. people that went to the first version of the database will notably see many differences compared to the first version. And of course, we still try to improve this more and more in the future of this project. Some of the improvements that we implemented compared to the first database that we have put online, and this was actually an iterative process where we involved some key stakeholders, not only to improve the database that we developed for the NEET project, but also to develop other databases that we have at Sciensano specifically. And we involve stakeholders, also people internally who are involved or have a general interest in knowledge translation. And the first step was that we implemented a tutorial, so a dynamic tutorial, so people have an idea of what is represented in the database, how they can change several factors in the database to get to the result or the estimate that they have. There is an easier navigation because sometimes people were a bit lost of where they had to go into the database to find specific things or criteria and estimates back. There is an interlinkage of tabs, which I will become clear during the demo, where qualitative data is linked to quantitative data, and it's easier to navigate between both. Two things that are not implemented yet, but where we are looking for in the near future, that is the access to additional information, and it will become clear what I mean by this is not optimal yet. We find back that users find this not optimal yet, so we try to improve this. And I didn't add this, but there was a question on comparison, and I think one of the solutions to compare unmet health-related needs that occur across different spectra of chronic diseases or different chronic diseases. This is also something that needs to be included in the database, because the database in the end will allow for this. It will allow for a ranking or an assessment of unmet needs disease-based, so from the disease perspective, but also across different diseases. So you can see which unmet health-related needs are generally very high across several different chronic disorders or diseases in general. The FAIR principles, so I think that most of you are aware of the FAIR principles. So the idea is here to make sure that people know the database, that's one thing, but also that it can be retrieved from other sources, or that you can find it back, and that you can also use it in a very efficient and efficient way. So what does it mean? It comes down to metadata. So it's important that all the information that we have in the data set, so all the estimates, all the methodologies that we used, that we have metadata about them so that they are clear for the users. Next to this, we also put all the data on the Zenodo platform. I'm not sure how familiar people here are with the Zenodo platform. Apparently, it's very popular to cite Greek philosophers and Greek people these days when you give a presentation. So Zenodo comes from Zenodotus, and it was actually the first librarian in the ancient Alexandria who was the first one who really put some metadata to documents that were in his library. And so that's the Zenodo project. So it was based on this concept of metadata. And the idea here is that this Zenoda library, it's a European project, by the way, which is important, that it allows for a very easy access to the data, easy access to the metadata, but also that you can track who uses the data and that your data set can also be cited. Because of course, if you want to increase visibility, it's important to know who is using the data and what they are using it for. So this allows for a very easy tracking of citations and also a good tracking of different versions. So of course, as our colleagues explained already in the beginning, it's not set in stone. We add still diseases. Some things might change to the database. It's a process that can change over time. And so then it's very important that there is some version tracking, that for everyone, it's easy to find back the version that they used for their particular research project, for example. If we look to the future, then there are some upcoming developments. One of them is, of course, very important to increase the usability. That is, somehow we have to come up with a color warning system, some kind of ranking, some kind of decision system where we can easily see which criteria have a very high unmet need, while which ones this need would be a bit lower. And that is also very visible and very engaging in the data set. Next to that, currently if we do a review, it's often with internal people from Sciensano or with the KSE that we go through the data set and see how can we improve it. One of the things that we also have in mind is, of course, to maybe interact more with different stakeholders outside of our own organizations to really see that the database and the interaction with that database really reflect what the needs are of people that want to use the data set. Unfortunately, there was no internet on this computer, but there is a tutorial. We made a screen recording, and it takes around 5 minutes, and it should start automatically now. So where can you find back the data set? You go to our website, and then on the upper right corner, you can see a link, which is Need Database. If you click on this, then you will see that you will go to our database, and you see that the first line, I hope it's visible enough, it's a tutorial. So if you click on it, that's the first thing you see. You get some extra explanations on how you can work with the database. So here, for example, it explains us that there are 2 diseases where we have many criteria and indicators that are filled out, how many diseases we have in general. The next thing you see is the exploration of the estimates, which are also links that you can click on to go to the different tabs that we have. Then we provide some additional information on what kind of methodology we use. So how do we come up with our estimates, where you can click on the different links which give you more information on the methodology. And then the next one is where you can download our data, and this will refer you to the Zenodo platform where I spoke about before, where you can have the full data set yourself if you want to make some additional calculations or have some additional assessments of estimates, which is maybe not directly available through this interactive data set. Then you end the tutorial on this page. So on each page we have a tutorial, and then you can click on either on this link here or either on the tabs on the upper right side. So per tab, or most of the tabs, we also have a tutorial. There are 2 options here. You can compare criteria within a disease. So then you can compare different criteria within one disease. So for example, here it's Crohn's disease that is given as an example, where you can click, for example, on, okay, impact general quality of life, impact on physical health. You can see on the right side and that both estimates are available, and if you click on them, then it gives you information on this estimate. If you hover, then it gives you the source and the year of the latest information that we have. So this hovering is not that efficient because some people take some time, so we still need to improve this. You can also compare between diseases. So now you can click on several diseases. You see that it's again available for all of these diseases. The idea would that is available next to that column, that we get this color warning system, that it's clear, like, okay, here the unmet needs are very high. And if you want some details, then you can see everything down there. You see, for example, and because we have a data set, the Belgian National Burden of Disease Study, which Rani will explain later. Sometimes we have estimates already for diseases on that specific indicator, so for that criteria, but not for all the other diseases. There is also a visualization tab where you can see some profile of diseases where we have at least some indicators filled out. So you will not find all the diseases here. Where you can click on the tabs, it's interactive, so you can see, get some additional information on these indicators when you hover over them. And currently we have like the tree where we have at least some indicators available. You also have the qualitative data with the interviews, where for Crohn's disease, for example, you can see several quotes that were given by patient and the key points that are related to those quotes. You can extend it where you see all the quotes and key points that were given for that specific criteria in the database. And then on the right side, if you click on open, then you get an immediate link. So it goes back and it gives you then the quantitative data that is related to the qualitative data that you saw there. You can also type for some keywords. So if you type, I'm interested in the pain experience, for example, in that specific population, then you find all the key points or the qualitative data that has pain in it. Methodology is, of course, also very important. So here you can see the two options. Either it's disease-specific, so where we did a case study, where we started from a specific disease. So hopefully soon we will add psychotic disorders to this. And you also have a database-specific tab, so where you can see the methodologies of databases that are integrated into the NEAT database with some links to additional information that is outside of our website. And then if all goes well, always very tricky to pace your speaking to a recording, but so far so good, I think. So here you can see all the diseases that are included in a specific database. So that's, for example, the Belgian National Burden of Disease Study with information on how we came to these indicators. And then you click again on the right side. I was just a bit too late, and you come back to the website. So that's a bit the idea. Again, it's a project in progress. We try to improve along the way to optimize the user experience. And I also want to thank, of course, all my colleagues who have to endure the endless feedback rounds and things that are possible and then things that are not possible. It's not always very easy to optimize everything, but I think what we have now is already certainly worth showing, and I would invite you to engage with the dataset and see for yourself how it works. Thank you very much.
Thank you very much for this very clear presentation. There will be time for questions later, but we will move on with the next speaker of this session, Rani Claerman. Rani has been a researcher at Sciensano for the past 2 years, and with a background in biomedical sciences. She focuses her work on the NEAT project and the Belgian National Burden of Disease Study. So the floor is yours, Rani.
Go ahead. So good afternoon. I will discuss the value of existing databases and the use of artificial intelligence for the expansion of our NEAT database. So the NEAT database is actually built on our NEAT assessment framework. So this was already well explained by my colleague Claudia, but this is very important to remind you because both the structure and the content of our NEAT database are based on this framework. So just to show you an example, so here we see the criterion impact on life expectancy, which is part of the patient health needs. We have identified 2 indicators to measure this, so years of life lost per death and years of life lost per case. Then you see the measurement method and, of course, the recommended data collection method. So for these indicators, we suggest to use database analysis. And this is also where my presentation will be about. So how do we go from the framework to our NEAT database? So we use primary data collection, as mentioned by the previous presenters, and we also use secondary data collection, so the databases, where we will focus on. So based on these databases, we retrieve data and we match it to our framework. So we make our own NEAT data set. Then we use the Shiny package in R to develop our online interactive app. So actually in a previous version of our app, there were only 3 health conditions included. And these 3 health conditions were based on the case studies we've conducted. And actually, the aim of this exercise was to expand our database by adding more health conditions based on other data sources. So we've identified relevant Belgian data sources for the NEAT database, and then we evaluated them based on the FAIR principles and also based on whether they are compatible with our methodology. So do they match with our framework that we've developed? And then we look at how many indicators are actually available in that data source. So if there were 3 or more NEAT indicators available for one health condition in a certain data source, we decided to include it in our database. So let's go to the first step. So let's explore the Belgian landscape of health data together. So as you may know, health data is scattered. It's scattered across different institutes, different registries. There's health insurance data, there's hospitalization data. And I've illustrated this as puzzle pieces, because actually today we're going to complete a puzzle together. And a first example is the Belgian National Burden of Disease Study, which is a project conducted by Sciensano, and they actually use local and national data sources, such as registries, to complete their own burden of disease puzzle. So they have a set of coherent and comparable burden of disease estimates for a large set of diseases. And another advantage of using the Belgian National Burden of Disease Study data is that it adheres to the FAIR principles. So it's easy to find, everybody can use this data and explore it. But before we can go ahead and use it for our NEED database, we actually have to take apart this puzzle, because we need to know what is actually included in this data set. So a first piece of the puzzle is a mortality data set, which includes data on YLL and the causes of death, which would be very useful to calculate the YLL per death, which is an indicator in our framework. Then the next data set is our cancer data set, which is based on data from the Belgian Cancer Registry, which also contains different indicators. Then we have our projections data set that contains estimates for the projected burden of disease, which is also part of our framework. And then last but not least, we have our DALI data set that also can be useful for the calculation of YLLs or YLDs for a set of 38 diseases. So what is the missing piece? Of course, we have to shape it to our NEED assessment framework. And if we look at the framework, we see that these are the criteria that are covered. So for impact on life expectancy, we could calculate the YLL per death and YLL per case based on this BEBOT data. We have the prevalence and incidence for cancers, for example, and then we also have some of the indicators for forecasted burden of disease. So this exercise was actually very valuable because we went from having only 3 health conditions in our database to having more than 80 health conditions now. But this exercise was also valuable to identify what is still missing, what are the remaining gaps. So we've included one data source, but actually we see that the burden of disease estimates, they don't cover the healthcare needs domains or the social needs. So this brings us to our next data source, which is the health interview survey. So this is also a project conducted by Sciensano. It's a household survey that actually covers multiple domains. So quality of life is covered, mental health, also experiences with healthcare, and also social health is included. So this is also a very relevant source for our NEED database. So we've not yet included this data in our database, but just to show you how many indicators would be available in this data set from the health interview survey. So there would be results for the EQ5D for, I think, 28 diseases that are included in the health interview survey. There are some indicators related to healthcare, so and also the absenteeism, so productivity losses could also be calculated, because in the HIS there's, for example, a question included on how many days a year the participant is absent due to a health problem. So if you now look at the framework when we would integrate data from the BEBOT dataset and from HIS, we already see that more of the criteria are covered. And actually, we also see that the healthcare domains and the social domain is also covered. So this exercise was actually very valuable because we saw that it does accelerate the expansion of our database. We went from having 3 health conditions to now having more than 80. By using BEBOT and HIS, we actually use representative data of the Belgian population. And another important point is that it puts no additional burden on patients. So it's data that's already out there, and we just have to use it. And then we've also encountered some challenges, of course. So it was sometimes quite hard to integrate this data. There's a lot of data cleaning and management steps that were involved. And then, for example, for the HIS, this project, this data is retrospective. So yeah, it lacks some flexibility. The questions were asked, how did this? And then we just have to match it to our framework, but we cannot really change these questions, of course. So you've seen the example of these two national data sources, but of course, as you know, there is way more data that's out there. And maybe some of the data we need for our NEED database is not found in scientific papers, but it could also reside in grey literature. So for example, in national reports or policy papers. And reviewing grey literature is actually quite challenging because it's also scattered, it comes in various formats, and we also have to assess the quality. So this is actually where the experts from the B12 consulting company are helping us. So they are exploring whether AI could help us retrieve data from grey literature. So there are a lot of AI tools out there, and especially for conducting systematic literature reviews, there are some very useful tools available. And some of these tools can search and identify sources. Some of them can even extract data, but they cannot really manage the whole reviewing process. So that's why these experts from B12 are mapping all of the AI tools and actually looking for the most suitable AI tools for the NEED database. So they've explored all of the AI tools and categorized them in different categories. They've defined some criteria, and they are evaluating them at this moment and also giving them a score. So in the end, we would have a nice set of tools that would be useful for the NEED project. So I'm looking forward to present these results in the next presentation, but for now, I can only mention that this is ongoing work. So thank you very much.
Thank you very much, Rani. And you will be back for questions at the end of this session as well. So the next speaker is Valérie Paris. She's a senior policy analyst in the health division of the Organization for Economic Cooperation and Development, also known as OECD. She joined the health division in 2005, and since then she's contributed to several projects on health systems characteristics and performance, providers' payments, pharmaceutical policies, and regional variations in healthcare use. And she coordinated and co-authored the OECD report's New Health Technologies in 2017, Pharmaceutical Innovation and Access to Medicine in 2018, and Securing Medical Supply Chain in a Post-Pandemic World in 2024. She's responsible for most OECD projects related to pharmaceuticals and medical devices. And between 2020 and 2023, Valérie Paris was appointed member of the board of French National Authority for Health, chair of the HAS Economic Evaluation and Public Health Committee, and vice chair of the Vaccine Committee. Very warm welcome to you, Valérie.
Thank you very much. Thank you very much for the opportunity to present an ongoing work. I think today you will have heard a lot about ongoing work, but I hope it's not too frustrating to not have the end of the story. I'm going to present you a project that we started last year at the end of 2024, and we do in cooperation between the health part of the OECD and the science and technology innovation part of the OECD. Let me find the, okay. The objective of this project is to look to what extent government funding for R&D is targeted to the highest unmet need in terms of pharmaceutical innovation. But we will look at the problem under different angles. We will look at first, we will try to define what are the unmet needs which could be available to pharmaceutical innovation, where we need drug. What we need the most is new drug. Then we will look at the public funding side, and at the end we will also review the demand side payment from the pricing and reimbursement policies that we have to also encourage new drugs for unmet need. So let's start by setting the scene about what is the public contribution to pharmaceutical R&D and consumption. From the demand side, the consumption, as you know, pharmaceutical spending accounts for 0.5 to 2.5% of GDP in OECD countries. This is very variable across country, and more than 50% of it is financed by public fund. When we are in Belgium, it's 75%. It's very well covered, like in many Western European countries. So this is for what the drugs we purchase in pharmacies, because for drugs that are used within hospitals or in physicians, as part of physician services, oncologists, for instance, that might not take place in hospital, this is not counted in that. This is counted apart. And you have, on average, for all OECD countries, to add another 50% to the figures I just showed, to take this into account. Again, it's very variable. Like in Denmark, half of their whole pharma spending is in that category, while in countries like Germany, it's less than 10%. So it's very, very variable. But this part of the public, this part of pharmaceutical spending is almost completely covered by public funding. If we look now at the research side and the financing of research, I'm showing you on this graph the business investment in R&D in pharma, which is the dark bar, and the government budget allocation to R&D in health, because we don't have the category pharma. This is health, because also this is a lot of basic funding, and we don't know at the start where it will be directed. So if we look at this slide, the first slide is in billion. Oh, sorry, billion. Sorry, dollars. You can see the US on the left. You see that what government spend is half what industry spend in the US, and it's true also for Europe. The figure on the right side is in share of GDP, so it's broadly equivalent, but this is to show you the proportion of what is spent in the different areas. China is missing, as you can see. Now, it is quite difficult to have a good idea about where public investment is directed in terms of R&D and in terms of disease. We have some indication about what happens in clinical trials. We can see the distribution of clinical trials on the left side of this chart, where you have the dark blue is trials where the primary sponsor is industry, and on the right, on the right side of the bar, where the primary sponsor is without any industry involvement. Sorry, clinical trials without any industry involvement. So it's not insignificant, and it's probably clinical trials for non-drug interventions. On the right side of this slide, I want to acknowledge the existence of other resources to look at public funding of R&D by disease. There is the WHO Global Observatory for R&D, which gives you some indication for 7 governments, among which the US, so it's not the smallest, it's a big part. For 80 categories of disease. There is also the Polycure Research Fender initiative, but it's more focused on neglected disease. And there is also the Pandemic Pact program, which is looking at public funding, but for pandemic preparedness and so on. So we built on that. We had some contacts with WHO team, for instance, to not restart from scratch what we are doing. So this, I will not go into the details because this repeats the three streams of work we will be doing. So estimating unmet need, the highest unmet need that should be addressed by new drugs, then looking at public funding, and then looking at payment incentives. The last part has not started yet. And about the other parts, I'm going to tell you what we are doing. So we read a lot of the need material because this is a reference in the field. We know that when we measure unmet need as a whole, I think it has been said already today, we have a global burden of disease can be due to the system inefficiencies. Like we know that some diseases are very poorly treated. COPD that I will mention earlier is a case because many patients do not follow the right care pathway. We have the example also of a high burden of disease of CVD in Eastern European countries, but at the same time, a very low consumption of statins or anti-cholesterol or anti-hypertension drugs. So the system is ineffective. It can be also because the treatments are just inaccessible. In the case I mentioned, it can be part of the determinants. And there is the last case in which we clearly lack effective treatment. So this is what we target in that study. We use the global burden of disease because we are working on 38 countries with a limited amount of time and resources, so we could not do as sophisticated methods as you did for Belgium. We know perfectly the limitation. We know that this institute, IHMA, is very creative, that you have a lot of proxy. We know all of that, but we could not find a better way to do it, which means that there is no chance we will get any rare disease by looking at the highest burden of disease. So we know all of this limitation. This is it was somehow a constraint for us. We did a lot of, analysis of this data. The database is extremely rich. It includes a lot of data on the current burden of disease. I don't need to explain because you've said several times what it was today, the trends, what is going on. But what we chose to do, to be a little bit more precise, once we have excluded all the accident and violent deaths that can have a high burden in some of the OECD countries we have, we clustered countries according to the similarities of their burden of disease based on the 10 highest burden of disease. And you probably cannot read. I will guide you through these 4 groups we have. On the right side, in green, you have mostly a group of Western European countries where we have a big burden, relative high big burden of disease for anxiety, depressive disorder. These are the biggest burden. Just next to that, in yellow, you have the group of New Zealand, Australia, Canada, Japan, US, with also specific Korea, specific burden of disease, with Alzheimer, which is also big elsewhere, but Alzheimer, relative high burden of Alzheimer, opioid disorder, and other type of disease. Here, this is the group of Latin America country when you have a lot of DALYs due to preterm birth, but also stomach cancer, so this would be the most characteristics. If you go to this slide after my presentation, you can read this, but this is a little bit complex, I admit, for a slide presentation. And here You have the group of Eastern European countries where, when I told you before, there is a lot of CVD, the very high burden of disease for CVD, for alcohol disorder, also some cancer, colorectal cancer, linked to also some of these risk factors. So this is what we had, and at the end, we chose to use this cluster analysis to define a set of countries we would be focusing on. So these are the other methods we could have been used, but we have preferred this one. And I show you on this slide the comparison with the study which was done in the Netherlands, on the Netherlands, because it's there is some commonality, like COPD, dementia is not too far. And we also have a major depressive disorder. And this is the list, or one list. I don't know if you recognize this list, but it was at least in one of the documents of the NEED project, where you can see the rare disease that we cannot have in our, by definition, definition in our group. So these are the three for which we are going to test the funding of R&D and see what has been dedicated to these diseases in terms of funding. So this is now, once we had that, we had to define whether these diseases were amenable to pharmaceutical innovation. Is a new drug really what we need? So the method we use for that is to select experts with academic publications. So there is a bias here. There can be a bias. I can see it, but this is the way we selected the experts. In experts who have published in the 10 past years in academic journal, and for which they have been ranked according to their I index, which is the number of papers that have been cited at least 10 times. So they are expected to be the leader academics in their field. This we found 55 experts with that method, and then we classified them in different clusters according to their expertise, specific expertise, because we have people really specialized in pathophysiology, looking at the biology or the etiology, what is happening, why people get ill, and how we can explain that. You have people more specialized in diagnosis, and people which are more specialized in lifestyle intervention and prevention, which were very underrepresented in that field. But this is also because of the focus on academic publication, because we would expect these people to be probably less represented in scientific publication. We contacted 16 of these experts. We tried also to have some regional representation, not all experts from the US, so we tried to have some representation. And we selected 16 experts. At the end, 7 accepted to contribute to the study. 6 responded to a questionnaire we sent in advance to questions about their understanding of the disease, the explanations, and what were the possible avenue for R&D and so on. Then we gather them in a focus group to get some convergence in their opinion, and we got some conclusion about what they think about the amenability of Alzheimer to drug treatment. So this group of experts agree on the fact there is a consensus that there is the Alzheimer disease is druggable, we wrote, but expectations have to be realistic. There is some encouraging results with the new drugs, but there are big gaps because the effect remains small. We have a lot of heterogeneity of older patients, and there is safety and cost challenges with these drugs, so we really need to have other approach. They suggest that probably multi-target and combination approach could be useful. And they also think it should be that Alzheimer's should be treated earlier than it is today. Where today we don't have medicines in many countries, so it can be treated. And about the specifics about what should be the public contribution to this research, they think that so the big bottleneck is the trial infrastructure, which is too slow, fragmented, and not funded enough, and that the shared priorities for the public sector should be like it's always, you know, what industries say, and there are probably very good reasons why they always say that the public role should be on the non-competitive shared platform, biomarker validation, adaptive efficient trials. So these are things that you often hear from the industry. I have 5 minutes left. That's okay. So this is the overall message about what could be public funding. Now, this does not come from our study, but we can not only look at public funding without wondering what is the private sector funding, because as you know, Alzheimer is not exactly a neglected disease. There is a lot of people in rich countries, so potentially this is a big market. So industry is also very interested in Alzheimer research. Let me start by the past, which is on the left side on this slide. In the past, so I found some academic papers explaining that since 1995, industry has spent 42 billion on Alzheimer's disease. The failure rate has been 50%, which is big. Even if for pharmaceutical development, it's always the failure rate is always very high, but this one is very high, higher than others. And for reference, they also mentioned that the NIH just in 12 years, because between 2008 and 2020, spent 16 billion. So it's not a negligible investment that NIH did in this field. Today, there are about 140 drugs which are being assessed. I reproduce this beautiful figure that I hardly understand myself because I'm not a clinician. So I find it really fascinating to see all the directions it takes to the development of this drug. About 30% of these drugs are biologics, another 43 are small molecules. They are addressing 15 different processes, so it's going in many directions. What I found interesting also is that repurposed agent is 1/3 of this research, and that biomarkers plays an important role in current trials to determine the trial eligibility and also the outcomes of the treatments. So this is what is happening from the private side. I will skip these slides because it's better if I focus. This slide was about depression, and what we did the same, work about expert focus group and so on. This is done also for COPD, and for COPD, maybe I can say just a few words because we had some anticipations about what we would find about COPD, and we think perhaps it's mainly risk factors, and it's also perhaps irreversible once you have it. But our experts did not say that at all. They said that it's also amenable to pharma innovation, and they are very hopeful that we can find some useful treatment. Let me now describe very briefly the database we have for the public funding of R&D. We call it OECD FundStat database, and this is a database which includes all project-level awards funded by public institutions. It covers, for the moment, 19 OECD countries and 56 data sources, which is a huge amount of projects. So we have more than 2 million project awards, and for accounting for 1.5 trillion US dollar since 2015. So this is a big database, and on this chart on the left side, people looking at screens at home would see better than you, I guess, what is happening there. We have the coverage of this database by comparison to yes, I'm finished, to the government R&D funding as a whole. If you look at France or Belgium, for example, the coverage is pretty small. I cannot explain for Belgium. For France, I know this is partly used to the fact that a fair amount of research is not funded by grants, like in the US, or it's funded. If you have a general funding to university or for an institute without specific terms, in which you can search it was for Alzheimer or for something else, you cannot have this grant text that we can use. So it's imperfect. This is what we can say. And in other countries, the coverage is not very good because we don't have the right institutes, or there can be other reasons. So what we will be doing now, and when I say will, it's fair to recognize that these are our STI colleagues, which are really the specialists of this data and of this method also to scrap information from these grants. So they have done this part for Alzheimer, which is to use the keywords we have found in academic papers everywhere to scrap the data and estimate the funding. They checked with the NIH funding I showed earlier. It works pretty well. Then they will look at the publication, the scientific publication that could be attributed to this public funding. They will try to do it also at the national level, to look at the national contributions and perhaps related to the national burden of disease for Alzheimer, for example, to see if, in countries with high burden, there is a higher investment and higher publication. And the type of results it can provide is this one. So it's not the result of this study because it's not finished. This one is a study that our colleagues did to see where R&D funding had been allocated. If you look at the societal goals of the UN societal goals, in terms of, if you look at the chart, the dark blue is the total of R&D funding. The proportion, of R&D funding, which goes to prosperity, health, planet, education, and so on. The second bar is the number of R&D projects, and the third is the number of scientific publication. This is for the period 2015 to 2023, which includes COVID, which might explain why health has been so well served during this period. And this is also a chart when grants have been grouped by their main societal goal. So this is the type of results we will have at the end of this project when everything will be put together. And this is all what I can present today. Thank you for your attention. And yes, the end of the project is to come, remains to come. Thank you.
Thank you very much. I'd like to invite the speakers of this session on the podium to take some questions. So who wants to kick off this Q&A session? Who wants to go first and ask the panelists a question? So you can move along so people can see you. Anybody? It was all very, very clear, I guess. No. Yes.
I have a question for Rani. It's about the databases. You include the Belgian Cancer Registry, but there are also registries from other diseases. Are you going to include these as well, or are they already included?
Yes, thank you. So indeed, we're also looking at other registries, but I think a main challenge when including a disease registry on itself, so the cancer registry, of course, includes a large data set, so a lot of data on cancer, of course. They have prevalence, incidence data, and so on. But disease registries, I think sometimes they mainly focus on clinical data, but these could be actually useful to calculate the prevalence, for example. So for rare diseases, this is definitely a very good option. So we're indeed exploring this as well. But for now, we focused on the bigger data sources. Yeah. Thank you for your question.
Any questions online, Charlene? No, nothing? Okay, if there are no further questions, then we can move on to the coffee break. The people who will be participating in the panel discussion just after the coffee break, they should head over to the technical team to have the headsets fitted. So just a short announcement. And thank you very much and see you after the break.